So, on the subject of perceptions continuing, what are allergists' perceptions? What are allergy clinics' perceptions of what they're doing? And I'd like to welcome Professor Bill Egner, who masterminded the survey and has, I think, the publications in press, let's hope, on what the allergy clinics report that they're doing at the moment. Bill.
Thank you very much. I think this session is called Perceptions and Reality. I can certainly do perceptions. I'm not sure I'm very good with reality, but I can tell you what the allergy clinics reported to us in advance of the main data collection with regard to their ability to meet some of the guidance that was existing at the time of this NAP6 baseline survey. So this was... So you don't need to read all of these, but just to show that we did attempt to map these to existing guidance. So there are three sorts of guidance that's available. There's NICE CG183, which is generic on drug allergy, but it has these N1 and N2 standards, which mostly overlap with the BSACI standards on identifying specifically the drug, what investigations you use, what drugs and drug classes you should avoid, safe alternatives, and structured written information to the patient. The AAGBI guidance really is the primary source for the mandatory reporting to MHRA by the anaesthetist. BSACI has a variety of standards which might relate to drug allergy, and the ones in red are the ones that we could investigate both in this baseline report and in the actual data, because there are some things like whether you have high throughput, high expertise and so on that we couldn't do in the main data set because it was all anonymized. But these are related really to the availability of skin testing, drug challenge. Again, all those overlap, identification of the drug, the safe alternatives, the mechanism. Reporting to the healthcare professionals that are involved, anaesthetists, surgeons, GPs. Given information to the patients, including a brief to whom it may concern letter, providing a medical alert bracelet. You've already heard that medical alert bracelets may not be distributed as widely as we would have hoped. Reporting to the MHRA is also in there, but BSACI is not specific about who should do it. Obviously we couldn't tell whether or not what the staffing of the clinics were. So, first thing we did was identify it's a relatively small world. If there are 11,100 anaesthetists, there are under 100 immunologists and allergists combined in the country. But we did, so we identified all of those and contacted them repeatedly via various sources. And the responses that we got identified centres in the following distribution, which is slightly different from the House of Lords Science and Technology report, which is talking about general allergy, food allergy, and the rest, where most of the centres were predominantly in the southeast, and there was relatively sparse availability of services elsewhere. But you can see that in terms of POA, there are more centres. We identified the small numbers, only 11 paediatric centres, 12 smaller adult centres who saw less than 20 cases a year, and larger, arbitrarily, we said more than 20 cases a year was a larger centre, so 21 of those. Of these 12, 3 have ceased to exist because the people who ran them retired since that survey. So these are shrinking, which again emphasises the lack of availability of services, which hasn't changed much since 2007. There's a scale missing, I'm afraid, from this, but we see both referral numbers estimated by the clinic. About 50% of the data is estimated and 50% is apparently real. Also we then used 2011 census data to identify the number of cases per population density and total number in each of those areas. And you can see that they vary widely and are universally poor for paediatric services and variably poor for the adult services. So, you don't need to read all of this. I'll just take you through it bit by bit to point out things that are important. But if we look at the elements of adherence to BSACI guidance that we were able to identify in the baseline survey, and we present the data of dark blue being the paediatric centres, these two being the adult centres, and the grey, obviously, larger adult centres will dominate, and they are more likely to reflect the data that we received in the final, and we'll discuss later in the final report. And I've given ticks where actually their perception appears to be correct according to the final data, because I don't think there's any harm in telling you that at this point and then exploring it in detail later. So, neuromuscular blocking agent panels. So, we identified what we thought was a minimum NMBA panel. We called it the NAP6 NMBA panel, which consisted of the NMBA that was suspected if it was an NMB reaction, and then SUX, ROC, and atracurium or cis-atracurium as a minimum testing panel. And we asked people whether they tested for a panel at all, or whether they tested for the NMBA panel. And in about half to 60% used the what we would regard as the gold standard NAP6 minimum panel. And in fact, that turns out to probably be true. And also, although the BSA guidance talks about using a panel, and obviously you'd think a panel was necessary to identify safe alternatives, relatively few people seem to be using a panel generally. Although if you top these two up, you've got about 80% of clinics using panels, at least multiple NMBAs. Latex. Obviously, latex in the past has been a very prominent allergen, and it would generally regard it as being important to be able to test for it in the BSACI guidance, and the general consensus of the NAP6 panel was that we should be continuing to look for it, and so routine testing would probably be what we would be expecting. But you can see that actually, although many people thought they were testing routinely for latex, in the end we found that wasn't true. And then a few people thought that they were testing to latex in selected cases. And again, we don't think that's true. We think quite a lot of people are missing latex testing these days. Chlorhexidine, another up-and-coming allergen. And again, about sort of half of, or slightly more of the clinics thought that they were going to test to chlorhexidine routinely, and we would generally regard that as being sensible. But in fact, it looks as though clinics really are doing that. And the rest would say, well, we wouldn't test it in everybody, we'd test it in selected cases, presumably those in whom they thought chlorhexidine might be a causative agent. Specific IgE tests, well, I mean, in general, allergists tend to default towards skin testing, but there are specific IgE tests available to a variety of drugs, certainly to chlorhexidine and latex and other sort of POA agents, but there's a much wider range than that. And we, although more than half the clinics identified they had specific IgE available, didn't specifically say they were using it. In fact, we think that these are relatively underused. With regard to being able to do both skin and intradermal tests, everybody said they could do it essentially, and we think that's probably true from the data. Drug challenges are available, although relatively infrequent, so I haven't actually marked that one. Identifying the culprit drug, well, everybody says they do it. There's no point having a clinic unless you think you can do that. Reporting to the referrer, yes. Reporting to the GP, yes. Everybody's pretty good at that. Reporting to the patient and guardian, well, in fact, most people, in fact, manage to do that. And were correct in their perception that they did so. But provision of medical alert information, everybody thought they were doing it pretty well, and in fact it looks as though that's not true. So if we move on then to communication standards. So again, a lot of these are derived from BSACI and NICE guidance. So, reporting to the patient, parent, and guardian, yeah, everybody thought they did it, and in fact they did. Written information given in clinic. People were honest in saying that they weren't very good at doing that, and that is effectively confirmed. Identifying the culprits, well, if most people identified the culprits where the culprit could be identified, but were very poor at identifying reaction type, even though most people thought that they were doing so. Identifying the clinical features, again, very poor. Identifying the investigations and listing the investigations used, again, very poor, even though everybody thought they were doing it. Letter providing avoidance information, well, I'll give you a cross there. Although most people did it, there was a significant number of cases which were judged poor because the avoidance information was not thought to be detailed or extensive enough. where the clinics knew that they were poor at giving patient support group information. That's the allergy charities that deal with supporting patients, Anaphylaxis Campaign, British Allergy Foundation, and so on. Allergy UK now. They also acknowledged that they were poor at giving immediate information to the patient. We think that all of those things are borne out by the final data. MHRA reporting. Again, the anaesthetists thought they were relatively good at, or at least the clinics reported that the MHA report was likely to come from the anaesthetists in more than half the cases, but that turns out to be untrue in that MHR reporting is generally very poor. Very few clinics sent a reminder to do the MHRA reporting, so obviously it's sensible to do it after the final conclusions are reached. And the allergy clinics themselves were at least honest in relaying the fact that very few of them actually did an MHA report directly from the clinic. And in fact, it was worse in the larger adult centres, so being around under 10% there. So, clinics, how available are they, and what's the access issues with regard to clinics? Well, delay in clinic assessment was acknowledged in the baseline survey, and the estimates of clinic availability were broadly true. These are split into the 12 smaller adult centres, the larger adult centre, which is more likely, it's going to dominate the stats, so we'd expect the main survey to mirror this more likely than the small number of paediatric centres and the small number of cases in the smaller adult centres. And you can see that the distribution for the routine adult appointments were thought to be happening somewhere between 12 and 8, peaking around 12 to 18 weeks, and that was generally true, probably closer to 18 weeks, and we'll show you that data later. The smaller centres thought that they saw people more quickly, but we can't interrogate that data because we don't know who reported what, because deliberately everything was anonymised. So we can't go back and subdivide people like that. But generally, that relatively poor level of service with long delays to achieving the first appointment was generally true, and people's estimation was approximately correct with regard to that. And finally, not finally, but NMBA testing, this is just to expand on the NMBA panel. So again, only about 43% of the larger adult centres were compliant with the panel, and that's broadly true in the data. Various differences in use of skin testing, the skin prick test and the intradermal test, two variants of skin testing, and then specific IG testing. In general, we thought that people did skin prick tests and then intradermal tests if negative, and I think the data broadly shows that's true. So what did they believe, the clinics believe they did well before we started the NAP6 survey proper? Comprehensive assessments. They thought they did comprehensive assessments, but I'm afraid the NAP6 data probably shows that we don't, at least not strictly. Achieving diagnosis, well, we show that they do, despite any deficiencies that we point out in the data later. Communicate with healthcare professionals, who were generally very good at that. We're generally reasonably good at avoidance advice, but where there were deficiencies, it tended to be in advising appropriate and extensive alternative drugs, as well as in communication with patients. And early access for urgent cases, we think that this is not, in fact, the case. I don't think we didn't actually interrogate the data in the baseline survey enough to say that people said they saw urgent cases quickly, but we've at least confirmed that that doesn't appear to take place. So there's room for improvement in communication, identifying the reaction, investigation details, and this was acknowledged in the baseline survey. Improvements in testing for collecting neuromuscular blocking agents and latex, again, that's confirmed. Waiting times for clinics, the baseline survey suggested that could be improved, and the data shows that that should be improved, and MHR reporting was acknowledged to be poor originally. So that's the baseline survey. Perceptions, in most cases, were reasonably concordant with reality. Thank you, Bill.
Thank you, Bill. If and when we're asking professionals to improve what they're doing in general, it's important that we can identify what they're actually doing rather than what they perceive they're doing. And that's where those two studies are going to be so useful in terms of beneficial outcomes from NAP6. Now, the next two presentations relate to those two surveys you saw bracketed together on the right-hand side of the schematic in my initial talk, that came out of the activity survey. So the first one, which is you're going to hear now, relates to anaesthetist activity and patient demographics. And the second one will relate to allergens and allergen exposure. And of course, the purpose of doing these surveys was to provide a denominator figure for the numerators that were coming out of the case report studies. And we're fairly confident that we have actually established true denominators. So, Harriet, I would ask you again to step up to describe the activity, anaesthetic activity part of the denominator study. Harriet Kemp, thanks.